Good morning, everybody. Thank you, Alexei. Again, thank you for the invitation. Just a quick run through for laparoscopic training, and just going to start again with the slide you saw yesterday. This is traditional training, where it's debatable how good the quality of training is there, and we don't really want to go back to those days, so we're just trying to change things now. I'm going to talk a bit about the laparoscopic learning curve. You saw this slide yesterday, I think, from one of the other speakers, but this was adopted from the aircraft industry, and it's been in surgery since the 1980s. We don't really want to go through the system again where that we had with the laparoscopic cholecystectomies, where the common bile duct injury rate went sky high, with open surgeons thinking they could do laparoscopic surgery, so we're trying to do this in a much more controlled fashion. The exact definition isn't entirely clear. Does it mean time to independence? Does it mean operating time, complication rate, length of stay? The answer is it probably means all of these things. So there's the typical learning curve, and what we're trying to do is actually move that learning curve to the left and speed up the time to independence and speed up to the point of the plateau. So that's the green arrow there. There's lots of factors that affect the learning curve. The characteristic of the surgeon. Daniela spoke a bit about that yesterday. The type of training is quite important. Gone are the days where you see one, do one, teach one. The volume is important to a degree. I think what's quite important is also the intensity of training. So doing 50 cases over a year or 50 cases over 2 months, the argument is that over 2 months you'll get quite good quite quickly. And specialty specific, so concentrating on your own specialty or subspecialty. Thankfully for all of us, these are less important. Age is less important. There's certainly somebody in England I know who went through a training program at the age of 63 and he did it very well. Size of practice, again, is less important, and the hospital setting also doesn't really matter. I think the point is that you can train anybody. This is a paper from London. There's a couple of authors you'll recognise there, Daniela Miskovic and Amjad Parvez, and they look at learning curves, and the conclusion was that really it takes about 40 cases to get to independence, or at least for the person to feel confident. So what we're looking at is how can we speed up this learning curve. NICE is a body in England, a National Institute of Clinical Excellence, which looks at national guidelines and national protocols. And in 2006 they said that every patient should be offered a laparoscopic resection irrespective of where they are. But the important point and the proviso they added was it should be by trained surgeons, so that's quite important. We see about 30,000 new cancers in the UK a year. 75% of these are resectable, and over 90% we think should be resectable laparoscopically. The problem with colorectal surgery, it's taken a long time to take off. It takes quite advanced laparoscopic skills. The learning curve is long, but it's not just about you, it's about the whole team. So we spoke a bit about the anaesthetics yesterday, avoiding epidurals, getting patients up quickly. Ward training's important. The nurses know not to take food to the patients. The patient has to go and get their own food, so they're up and around the next day. And cost has also been an issue with laparoscopic colorectal surgery on its introduction. In the UK, the training is really threefold. The trainees are called registrars in England, and the specialist registrar training program, which is a generic training program. There are specific fellowships for laparoscopic surgery. And for consultants, there's this thing called LAPCO, which is a national training program introduced by the Department of Health a few years ago, where established consultants and established laparoscopic experts go and teach other consultants laparoscopic surgery. So on the left, the registrar is based on regions in England. We call these regions deanery. The problem here with laparoscopic surgery is that the training is very variable, because the consultants often themselves are going through their own learning curve and aren't really in a position to teach registrars how to train. And the other thing is, if you've got 2, 3, 4 registrars, there's often quite a bit of competition for cases. The fellowships, they were introduced, national fellowships. These are with recognised experts in laparoscopic surgery. They've tended to be industry sponsored, and they're independent. The LAPCO training program started a few years ago now, and initially there was 10 training centres, And the model was that these training centres had trainers who were approved, experienced laparoscopic surgeons who were in a position that didn't disseminate their expertise and train other consultants. And the real focus and the aim was that every patient and every hospital should really have access to a laparoscopic colorectal surgeon, so the patient didn't have to move to other units. There's a few training methods. Importantly, there's team training. As I say, this isn't just about the surgeon, this is training everybody from the anaesthetist, the theatre staff, to the nursing staff. And I spoke a bit yesterday to somebody about the recovery staff also, because, you know, we're trying to avoid morphine in these patients, so it's a very sort of holistic training program. The courses can be run as master classes, which is what some of you will have experienced in Portsmouth. There are cadaver labs where people go and learn on cadavers, and wet labs where you have, you know, pigs and things to operate on, usually in Europe. The preceptorship, this is really through the LAPCO training program. We have outreach preceptorship where the trainers visit trainees in their own hospital. So the trainer would go and visit the consultant in their own institution and watch them and tutor them and mentor them in laparoscopic resections. There's preceptorship at the training centre itself, so this is where the consultant would come to the trainer and either bring their own patients with them or more likely operate on the trainer's patients. The advantage of the former, the first one, is that actually I think it's very different operating in another environment. Operating in your own environment with your own team is much more beneficial. The sign-off from the NTP programme has thought to be about 20 cases. And there's an agreement between the trainer and the trainee that these are acceptable and suitable for submission. The final assessment, the videos that are taken, each of these videos are taken and sent to the central programme, and they're assessed by two independent trainers who have no idea about who the trainee is or who the trainer is, so it's double-blinded, and the whole process is audited. And then there's more the international training, which is what Amjad Parvez is doing at the moment. The thing about international training, I guess, is you're going to pick your trainer, somebody who's got an international reputation, who you know is going to be able to train. You visit their centre, which gives you exposure and familiarity to their techniques. And then the trainer visits you and preceptors you in your institution so that you're signed off with laparoscopic resections. And then that puts you in a key position to disseminating the training in your own country. So just to summarise, hopefully from the past, these are old pictures of how, I guess, surgery used to be and how theatres used to be, and we're trying to make a modern transition from there to the future, which is modern theatres with modern surgeons. Thank you very much.